Hello and welcome. I'm your host, Neil Howard. Thank you for joining us here on Health Professional Radio. In this segment, we're going to be speaking with Dr. Firas Zahr. He's joining us here as an interventional cardiologist and co-director of the Complex Heart Valve Program at Oregon Health and Science University. He also serves as Director of Interventional Cardiology. He's going to talk about the findings from the Intrepid study. Welcome to Health Professional Radio, Dr. Zahr.
Oh, good morning, and thank you for having me. It's an honor and privilege to talk to all of you.
I did, of course, mention that you're joining us here from OHSU. I mentioned a couple of your positions there. Tell us a bit about yourself and your area of expertise.
Yeah, so I'm an interventional cardiologist by training. I am extremely interested in minimally invasive, especially transcatheter therapy options for various valvular heart disease, including aortic, mitral, and tricuspid. And it's been a very exciting couple decades for transcatheter valve therapy, starting with the aortic valve replacement. That is right now the mainstream for treatment of aortic stenosis. And now we start generating the data that is needed to have transcatheter mitral valve replacement as an option for patients with severe mitral regurgitation.
The Intrepid Early Feasibility Study Intermediate Term Outcomes. Why was the study conducted, and where was this data presented?
So the Intrepid valve is a really novel technology. It's a two-stent design. The outer stent conform to the anatomy, and the inner stent is that houses the valve. And we started doing this procedure via the transapical axis, a small incision on the left side of the chest. You know, that transapical axis has, many complications related to the size of the sheath that the valve goes through, as well as the apex was really causing a lot of bleeding and arrhythmias, pain and discomfort to the patient. So the Intrepid early feasibility study looked at the concept of delivering the exact same valve via the transfemoral axis. So they developed, Medtronic has developed a sheath and a transfemoral delivery system that goes via the femoral vein, via the intraatrial septum, and then place that valve in the mitral annulus. And the exact same valve, the exact same position that you deliver it via the transapical axis, now you're able to deliver it via the transfemoral axis. The study was presented the 30-day outcome last year in TCT, and the findings were extremely encouraging as an early feasibility study, showing that we had zero mortality, zero stroke. Most of those patients went home in about 5 days and did very, very well. Very, very few patients required to go to cardiac rehabilitation or a nursing facility. The vast majority of their patients, almost 90%, went home to their original home living, to their dining table, to their meal, to their plates, to their forks. No change in their lifestyle. And what we have noticed is they have done better. Their quality of life has improved. Their heart failure symptoms has improved, and they've done better. What we presented in TCT this year is the one-year outcome for those patients who crossed the one-year mark in their follow-up. And what we've actually seen is the improvement that we've seen early on has actually sustained to 1 year. The valve hemodynamics were excellent. Most patients had no or very mild mitral regurgitation. No patient has any perivalvular regurgitation, and they continue to enjoy great quality of life and free from significant heart failure symptoms. The hospitalization rate was low. The mortality remained at zero, and so was stroke. So it's a very encouraging result for an early feasibility study, yet small number of patients, but at least it gives some hope that the technology of replacing the mitral valve may be catching up a little bit to the rest of the therapies that is available for severe mitral regurgitation.
Was there anything that surprised you particularly about this data?
Yeah, so we did not know what the data is going to show. We said, okay, maybe the 30 days outcome was good. It's a transfemoral system, and this is what we expect. But it was a very small number of patients. It was only 15 patients is what we presented last year. This year we presented 30 patients. So, the number of patients increasing, yet it's still small, but it's steadily increasing, and we're able to maintain, the good outcome. What we've also noticed is, the procedure time is about 45 minutes. And between the time that we enter the sheath in the body and the time that we take it out. So despite the fact that we're early on in the experience, most centers of excellence in the country were able to deliver those valves in a relatively short period of time. So the learning curve, as well as the ability to make the procedure generalizable, has been impressive. What also surprised us is we were able to maintain, despite early experience, we were able to maintain a very good outcome at 30 days. And unlike, for example, the transapical access, where obviously the valve is the same valve, so that the patient's valve are doing okay, but the improvement in quality of life and heart failure happened very quickly in the transfemoral access. The patients were feeling better already at their 1 month follow-up, as opposed to the transapical access or surgery, where they're still having pain, recovery, and at the 1 month follow-up. And so those probably was the most surprising findings of the study.
How do you think this data will evolve in the future? How will it affect this type of procedure going forward?
Yeah, so this is really, really good question, because as you know, in the same conference, there was another device for edge-to-edge was FDA approved. The Pascal device got FDA approved. So now we have 2 devices for percutaneous repair of the mitral valve. However, there's still significant number of patients that are not suitable for repair due to their anatomy, or they're anticipated not to get good repair with those devices. So the mitral valve replacement right now is surfacing as an option for those patients. And now with the transfemoral system, and if this encouraging results continue to be as a larger population and a longer follow-up, then we might be talking about an additional option to treat complex mitral valve disease. What happened last year is that valve, the Intrepid valve, has entered into the pivotal trial via the transfemoral system. So now it's available for larger patients, yet still in clinical trial, but it's available to a larger patient population in a lot more centers, as well as there are a lot more procedures that are being done than what was presented in the early feasibility study.
How about patients who aren't necessarily experiencing problems with the traditional valve that they have in place, but because of the nature of those valves, it is anticipated that they will experience problems? What about replacing those valves with Intrepid, even though there are no complications at that point?
That is a very good question. And I think as we gain confidence in the technology, as the technology gets safer and safer, the next question comes is, when is the ultimate time to treat those patients? Right now, in the clinical trial, we are limiting this therapy to patients who are high surgical risk, which means that they're anticipated by their STS score or by the heart team assessment that they're going to have prolonged or complex post-op recovery. And they have to be symptomatic with moderate to severe or severe mitral regurgitation. Those are the patients that have been enrolled in the clinical trials right now. However, as we gain confidence with those therapy and they get better, the question, can you start putting those valves earlier and earlier in the disease process before the patients become symptomatic or before the permanent damage starts? And I think that with transcatheter therapy, we are still we're still behind. We haven't got there. With some of the younger patients who are asymptomatic or expected to have good valve repair, yes, we might be offering them early surgery for repairing their valve. But until we know more about the longevity of the valve, especially for the younger patients who are not very symptomatic yet, the recommendation is still to wait and see, unless they start having heart failure or they're showing signs of damage to their heart from the mitral regurgitation.
Well, Dr. Zahr, it's been a pleasure speaking with you this morning. Thank you so much for your time.
Thank you. And I hope we meet again soon to talk about more data and hopefully more positive outcomes of the Intrepid valve. Thank you.
Thank you. To learn more, visit the Apollo Intrepid Transcatheter Mitral Valve Regurgitation Clinic trial at Medtronic.com under the Healthcare Professionals tab. You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Firas Zahr. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes. Listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.